All right, we're gonna go derm, eyes, ears, throat stuff. Hopefully this doesn't take too long. Let's start with macular degeneration. This seems to be becoming more and more common. So these are your treatment guidelines. The American Academy of Ophthalmology has age-related macular degeneration, used to be ARMD, and then the Euretina is the European Society for Neovascular, or what we'll call wet AMD. So there are basically two types. It used to be commonly called as dry, but now it's called early, and it's atrophic, non-neovascular. And if you look at the pathophysiology, the vascular type is basically a bunch of vessels being formed that shouldn't be, and these vessels don't mature properly, and so because of their immaturity, they're actually weak vessel walls, and they tend to bleed. So that's what causes the wetness of a macular degeneration. So in this dry one, that's not the issue. It's just atrophy. And so this is the most common type. The wet one or late type of macular degeneration is what I talked about with that neovascularization. And as you can imagine, this is going to be more damaging. Then there's something called Best disease, but we won't go into that. So AMD classifications, no AMD, makes sense. There was a huge study, and I think that Bausch and Lomb, which is a huge eye company, funded this study, but it was called the AREDS study, which is the age-related eye disease study. And so they had four classifications. You either don't have it, or you have an early type, or an intermediate AMD, or then advanced AMD. So factors associated with developing macular degeneration include age. Most folks are going to be older than 50 years old. If you have family history, much like everything else, women do tend to have a little higher incidence than men. If your ethnicity is white, if you are exposed to cigarette smoke, cumulative light exposure, and hypertension. Other things include higher summer sun exposure, excessive alcohol intake, and they do have some of the genes that are predispose you to macular degeneration mapped out, and so these are some of these genes. And then after diagnosis, obesity is also associated with increased risk for disease progression, and having physical activity, which then would usually mean you're going to be less obese, that would lead to a decreased risk in disease progression. Okay, so it's really easy for the treatment of dry AMD. Again, that's the more common type. It's called the AREDS formula, and this one is Bausch and Lomb's product. And you can actually go to the pharmacy over the counter, look at the eye section, and they sell it. It's called the AREDS formula, and it's indicated for dry macular degeneration. Let's see what's on chat. Diabetes. I don't know if it wasn't listed, but yes, I probably would consider diabetes. I'd have to look into that, Evninder, but you can imagine most folks are going to be obese. The glycosylation of cells would probably hit the eyes as well. And so you would see either macular degeneration or diabetic retinopathy. So that's a formula. They've came up with two types. One was the AREDS formula, then they reformulated it to the AREDS 2 formula. Um, so you just kind of see that. You can see there's copper added, which is a little bit weird. But zinc was found to be a part of the formula that helped with the macular degeneration. However, um, it's not enough to prevent zinc deficiency, and so they have to add cupric oxide. So the copper doesn't really do anything, but it's just added to avoid zinc-related copper. Oh, sorry, copper gets deficient. So having zinc in there can drive down the copper, and so they have to add copper just to prevent that copper deficiency. But otherwise, you're looking at vitamin E, an antioxidant, right? Beta carotene, which is found in carrots, lutein, those kinds of ingredients that have been known to be healthy for eye health. And then, so that's dry. When you get down to wet, which is a problem of neovascularization, you're going to look at these, what we call anti-VEGF drugs, which is vascular endothelial growth factor, VEGF. So these are anti-VEGF drugs. So looking at these, ranibizumab, aflibercept, faricimab, brolucimab, and bevacizumab. These are all agents that help shrink down that neovascularization. The only way to apply these medications is to do an intravitreal injection. So if you've ever seen that, you basically ophthalmologist is taking the needle, shoves it about 90-degree angle into the eye, injects the stuff, and it's done roughly every 2 to 3 months, depending. And they'll do an Amsler grid to see how the patient's doing with their usually their peripheral vision, and to see if there's any loss of vision there. And if there's not, then they continue on with the therapies. So invasive. Luckily, it's not every day. It's every few couple of months to a few months. Ranibizumab and aflibercept. These do have eye indications. Avastin here is actually for chemotherapy. And what they used to do is when bevacizumab was one of the first ones that came out, and so they took the IV vial and they would actually just draw up syringes and use that intravitreal injection. But since then, they've come up with like Lucentis, and it's actually formulated for the eyeballs, and so they stopped. Whereas most places will stop using bevacizumab alone for that indication. Does that make sense? So yes, ranibizumab is actually FDA indicated for macular degeneration for the eye. Bevacizumab is not. It's just for chemotherapy, but some ophthalmologists might use it still for that indication. All right, and then if you're not going to drugs, there's laser photocoagulation surgery. Some other vitamin preparations that contain lutein and zeaxanthin. There's not enough evidence to support that. Like I said, the AREDS formula was specifically designed by Bausch and Lomb, and they did study it in that AREDS study. And for whatever reason, that specific combination of vitamins and minerals was found to help reduce dry ARMD. So in summary, dry AMD is more common. Patients older than 50. Classic hallmark symptoms is central scotoma, which is like a black spot, usually in the central part of their vision. And then the AREDS formula for the dry AMD slows the progression. And then when it gets down to wet, you have to rely on anti-VEGF medications. All right, questions, comments? Oh, fun stuff, I know. Okie doke, moving on. Glaucoma. All right, so American Academy of Ophthalmology, this is primary open-angle glaucoma, or POAG. We'll do with the two most common types. So primary open-angle glaucoma is kind of your bread and butter glaucoma. That's your common type. Everyone's walking around with that. Acute angle closure glaucoma is a medical emergency. If it's not treated, you can lead to permanent blindness. Then there's the folks that have congenital glaucoma, and oftentimes these folks will present with glaucoma even though their intraocular pressures may be normal to the higher side. And then secondary glaucoma is kind of like caused by something. So risk factors include advanced age, if you have African or Latino ethnicity, family history, genetic predisposition, elevated intraocular pressures or IOPs. That would be termed ocular hypertension. If you have a thinner central cornea, if you have low ocular perfusion pressures, if you suffer from myopia, or if you have type 2 diabetes, migraines, or high blood pressure. So for prevention, the AAO doesn't recommend community screenings because it's not a cost-effective intervention, but it may be beneficial to target some of those high-risk populations that we just reviewed, especially those who are greater than 50 years of age, or if you have diabetes, or if you have a family history. So presentation and diagnosis, usually if the IOP is greater than or equal to 21, that's higher than normal intraocular pressure, and that often precedes glaucoma. It's usually asymptomatic in the early stages, but it can develop to a noticeable tunnel vision and scotomas, those black spots that I was talking about. And patients with acute angle closure glaucoma, which is that medical emergency, it's generally unilateral. They present with ocular pain. Oftentimes the eye can be red, and they'll have blurry vision, halos, and a headache. All right. Screening procedures, there's something called Goldman tonometry. It's a reference standard for diagnosis and should be performed before you do a pupil dilation to assess for the intraocular pressure. Normal IOP is generally around 10 to 21. So again, anything higher than that would be considered glaucoma. It does IOP does exhibit diurnal variation, and if you remember what that means, it just means that in the morning tends to be higher, then it goes lower, and then evening it gets higher again, right? So there's kind of a wave to it. There's other labs that are like that. Iron, for instance, when you do an iron certain iron level, that also tends to exhibit a diurnal variation. Um, Gonioscopy should be used to evaluate the anterior chamber angle because oftentimes these folks can't clear their humor, and so the fluid tends to back up, um, elevating the intraocular pressure. And so there's other diagnostics there for you to read. And diagnosis based on several factors. So physical exam, you're gonna look at the cupping diameter, but basically IOP is what you're looking for. So we'll go over the medications in a bit. So typically we're going to target a reduction of 20-30% IOP from baseline to delay visual field loss. Okay. And the earlier we intervene, the better the chance of maintaining normal ocular pressures for folks. And so aggressive management, early management is really important. Okay, some ocular rules. Only one drop is necessary per dosing, so there's no need to do 2, 3 drops. One drop's enough. If the ocular pressure is high, it's not uncommon to do 2 and maybe even 3 agents. And so just to make sure that there's enough contact and absorption through the eye, it's generally recommended that you do 5 minutes in between drops. There's really no preference to the order of the drops. You just got to make sure that you've given enough time for the absorption to occur before you move on to the next drop. Okay, so you can see these are the mechanisms. You're either going to decrease aqueous production, and so there's only 3 agents that do that. It's the beta blockers, carbonic anhydrase inhibitors, and adrenergic agonists. And the other mechanism, or more common mechanism for reducing ocular pressure, is to increase outflow. So like I was saying, there's that angle in the anterior chamber, and what you're trying to do is just kind of opening that gap so that the aqueous humor can flow out. And so you can see that prostaglandin analogs, adrenergic agonists such as epinephrine, pilocarpine, and this new one called rho kinase inhibitor helps to work through this mechanism. Okay, so this is kind of the flow chart, right? So you're just kind of reviewing, seeing where they lie in terms of intraocular pressure. And you can see that for the most part, the prostaglandin analogs are generally your go-to medications. They are effective and they're generally more well tolerated than the other agents. So usually when it comes to initial choice, a prostaglandin analog is kind of the main switch, the main medication. If it's for whatever reason you can't do a prostaglandin analog or you need to go to a secondary agent, then I would go to a beta blocker because that's another effective medication and also pretty well tolerated. And we'll go over the other agents as well. Okay, so these are your prostaglandin analogs. I'm sure many of you have seen Lumigan or heard of Lumigan. This is by Metaprocess. I think the first one that came out. It's stored in a refrigerator, but it is kind of the gold standard medication. Latanoprost is room temperature. Travatan, same thing. So these are all pretty similar to each other. I don't think there's any one that's proven superior over the others. This one you'll see that there's latanoprost BAK, which is benzalkonium chloride. Some of these have preservatives. Well, actually, many of them have preservatives, right, to keep them lasting throughout the entire bottle. But a lot of folks will have sensitivities to the preservatives. And so they'll get like redness, their eyes may burn when they put it in. So a lot of those folks with sensitive eyes demand or require preservative-free type of eye drops, right? So it's nice to know that this one actually does have a benzalkonium chloride-free formulation. Okay, these tables are, kind of detailed information on these agents. I'll just point out a few things. So again, the prostaglandin analogs pretty well. They do increase brown pigmentation of the iris. So just keep that in mind. It can be permanent. So you just want to warn people that their eyeballs, the iris itself, might darken a bit. So if they're not into that, then this may not be the agent for them. It also can increase the thickness and fullness of their eyelashes. And they actually do make a product called Latisse, which is by Matapros. Oh no, Latanoprost, which is actually has a cosmetic indication specifically for making eyelashes look full. That eyelash fullness is generally a temporary side effect. So once you stop the medication, the eyelashes go back to normal, unlike the brown pigmentation of the iris. Okay, you see there's ocular dryness, blurring, sometimes itchiness, burning. Generally, that's attributed to the preservatives. So if they have that problem, try to find something that's preservative free. And like I said, generally number one treatment because it has the greatest intraocular pressure reduction, and it's pretty well tolerated. Okay. Also think, yes, there's limited systemic absorption through the eyes, right? It's not the most desirable administrative path for a medication, but you do absorb some, right? So you gotta just keep that in mind, and we'll see that with the other agents. Okay, I'll stop there. Any questions, comments so far? Everyone's good. Okay, moving on. All right, next one, our second line, beta blockers. You guys know what beta blockers are. These ones are non-specific, right? So they're not really specific to like beta one or like the oral agents or the IV agents usually are. So Betaxol, levobunolol, timolol, these are all beta one, beta two, non-specific. Being that they're non-specific, they do tend to cause more side effects, and you can just apply what you know about beta blockers, right? So they can cause bradycardia, they can cause hypotension, et cetera, et cetera. But like I said, usually it's okay because they're only doing one drop, and it's limited absorption, but it is possible. Okay, so you can see severe cardiovascular respiratory events reported, but some of them make sense, especially the respiratory one. I just said it's not specific, so it could block beta 2 receptors, which are generally in your lungs, causing bronchoconstriction. So that might be an issue. Again, you can see you can add it to a prostaglandin analog. It tends to decrease more of the IOP, but usually it's second line or in addition if need be. All right, moving on, alpha 2 agonists. If you remember alpha 2 is centrally acting, it's in your brain, and anytime we tickle your alpha 2 receptors, there's a decrease in the amount of sympathetic drive, so less norepinephrine, epinephrine, dopamine, that kind of thing. So there's two agents here, apraclonidine and brimonidine. Brimonidine is probably the most common one. We see this alpha-GAN-P. It is contraindicated in children under 2 years of age because it has been associated with apnea and bradycardia. So if it's being used for that congenital glaucoma for children under 2 and they really need an alpha 2 agonist, make sure that you go with apraclonidine instead of brimonidine. Okay. So here are some of the things. Tolerability is not so great, right? There's some tearing, ocular inflammation, dry mouth, altered taste are some of the side effects. And then these ones generally are 3 times daily applications. So for adherence wise, they suck. Whereas the prostaglandin analogs are generally once a day. Let me go back. Yeah, once a day in the evening for prostaglandin analogs. So okay, cool, works all day. With the beta blockers, generally once or twice daily, so it's not super bad. But you can see that these are 3 times a day, so it's going to be much worse. All right, carbonic anhydrase inhibitors. I'm sure you guys have seen this. We do know about oral acetazolamide, Diamox. Everyone's kind of seen that. It also comes IV. There's also something called methazolamide or neptazane. And then for the topical eye drops, we have two of them, brinzolamide and dorzolamide. Um, so here's some of the side effects. They do cause a lot of stinging, altered taste sensation. These are also kind of 2 to 3 times daily applications, so they're not super great. Um, they also don't affect the intraocular pressure as efficaciously as the other agents. So again, more like a third, fourth line type of agent. So just keep that in mind. This is the newest type of agent. It's a Rho kinase inhibitor called Notarsidil or Ropressa. It has some side effects, conjunctival hyperemia, as well as conjunctival hemorrhage and corneal disease. So it can cause some sight pain. And it's not super effective. It lowers the IOP by like 5 millimeters 5 millimeters of mercury. Um, so it's going to be interesting to see. Maybe we'll get some other agents in this class that are a bit better tolerated and more effective. Um, but the nice thing is it is a once daily administration. Okay. I don't know if I no, I didn't talk about it. When it comes to acute angle closure glaucoma, basically you're going to throw the kitchen sink at them. The patients get all the medications, so you're going to throw a prostaglandin, a beta blocker, an alpha 2 agonist, maybe even a carbonic anhydrase inhibitor. And generally, the IV version of Diamox is also thrown at them. Because again, if we don't reduce the intraocular pressure quickly, that person may lose their eyesight. So that is usually the treatment for acute angle closure glaucoma. So everything plus IV Diamox. Okay, none of these things work. You can get a trabeculectomy. They just kind of open up the pathway for the humor, the humorous liquid to kind of exit. And then there's some other things that they can do, which I'm not super familiar with. So, all right. So in summary, open angle closure glaucoma or POAG is the most common type of glaucoma. You want to try to reduce the IOP by 20 to 30% from baseline. PG analogs are the best bet because they're once daily in the evening with the greatest IOP reduction and pretty well tolerated. And it's not uncommon, like I said, to use at least two agents. Generally, you're going to go with your beta blockers next, and then from there, maybe an alpha 2 or a carbonic anhydrase inhibitor. That's glaucoma. Any questions, comments? Okay. All right, moving on. Dry eye syndrome or dry eye disease, DED. So here's the practice guideline. Caused by one or two factors, reduced tear function or tear film instability or the evaporation of tears. I think it's supposed to last like 12 seconds. Don't quote me. But if your tears start to evaporate before this 12-second mark that I'm probably making up, then you have dry eye syndrome. I have dry eyes, so hence I always wear glasses. I can't wear contacts. They just totally kill my eyeballs. All right. Factors associated with developing dry eye: older than 65, female sex tends to happen more. And then a lot of the medications that we've talked about through this class, antihistamines, right, because of their anticholinergic properties. Some of the antidepressants, so look for the ones that have anticholinergic properties, like tricyclic antidepressants, right? Anti-anxiety medications, oral corticosteroids, systemic retinoids, and diuretics, which kind of makes sense to dry you out. Other things that may happen, postmenopausal estrogen therapy can do it. If you've had LASIK, it can tend to cause dry eye. A lot of my employees at work have done LASIK, and yes, they have to use drops a lot because they suffer from dry eyes. Vitamin A deficiency, and then if you have any of these medical conditions, rheumatoid arthritis, sarcoidosis, something called Sjogren's syndrome, which we'll talk about in a little bit, but that tends to cause quite a bit of a drying syndrome in the eyes. SLE, and then rosacea. Oh, and smoking. Okay, so dry, irritated eyes, redness, they'll be scratching it usually. So just look for that type of symptomatology. Like I said, there's a tear breakup test time. I don't remember the time, but I want to say it was 12 seconds. I'm probably making that up. And then some other tests that you can apply to see if they have dry eye. Potential complications, if we don't solve the dry eye problem, you can get corneal ulcerations. Nobody wants that. Vision loss, infections, neovascularization, and also scarring. Okay, so treatment. You can use a lot of the OTC ocular lubricants. Um, Generally, they're all kind of the same, not one's better than the other. A lot of them are like polyethylene glycol or methyl cellulose. Um, I'm not going to ask you what these ingredients are, but generally these are what these ingredients are reserved for. So really, it just comes down to patient preference. Obviously, the gels are, you know, kind of gooey. So that's good for patients who like want to use it like at night, and it kind of helps to lubricate their eyeballs during the night. Generally don't want to use that or ointments during the day because it's like sludgy, right? And it might cause blurry vision. So that's something to keep in mind. Review their medication profile. If they're like on Benadryl or any other really potent anticholinergic or diuretics, that might be contributing to the problem. So just kind of keep that in mind. Smoking cessation, and especially if they don't smoke, but they're in a household where they're exposed to secondhand smoke, it might be time to get away from that. Low humidity environments, hot compresses are helpful. Um, Frequent breaks from reading and computer screen. Unfortunately, I'm sure most of us are staring at computer screens all day, especially me, so that's not good. And then sunglasses to help reduce kind of dry winds and sun while they're outdoors. Okay, if the OTC options don't work, then we go into some of the more serious prescriptions. One of the first ones that came out was something called cyclosporine. Um, and that product was called Restasis. This one was specifically indicated for Sjogren's syndrome for the dry eye. They come in preservative-free little vials, so it's really good for those folks who have preservative issues. You're not going to run into that problem. But this helps to suppress tear production or reduces ocular surface inflammation that it leads to tear production. So pretty well tolerated. There's maybe some blurry vision and burning sensation. Um, it's not the most portable thing because you have to bring all those vials with you if you go traveling, because it's preservative free. So that'd probably be the only drawback, but otherwise, pretty well tolerated. This newer agent is a LFA1 antagonist called lifitegrast or Zedra. This one prevents a specific protein on white blood cells from binding to another protein called the ICAM1 in eye tissues. And by preventing that, we're also preventing T cell activation and inflammation, which can lead to dry eyes. Pretty well tolerated, may cause dysgeusia or local irritation and decreased visual acuity. Some other ones are cholinergic agonists. We've talked about anticholinergics causing dryness, right? Cholinergics cause sludge. So that's basically what we're doing here. So we're activating muscarinic receptors on the lacrimal and conjunctival cells, which can cause tear production. So there's a few agents. Cevimeline is one, and Voxac. Pilocarpine is the other one. Both are indicated for xerostomia in patients with Sjogren's syndrome, but they do improve tear production. Of course, if you absorb too much, then you're going to get all the cholinergic side effects, including diaphoresis, dyspepsia, excessive salivation. This is upper respiratory tract infection, maybe associated with a urinary tract infection as well. Some other options, this is loteprednol. It's a steroid. This is generally just used for 2 weeks. So if you don't think it's a chronic condition, loteprednol might be a nice little agent to use just for a temporary purpose. This next agent, varenicline, I don't know if you guys remember where varenicline is from, but it's a smoking cessation product, right? So they actually made a nasal spray formulation. This one's Tyrvaya, and for whatever reason, varenicline works on nicotinic receptors that are believed to treat dry eye disease, and this activates the trigeminal parasympathetic pathway, which then increases your basal tear film production. So I don't know, it's kind of nerdy. I'm super nerded about it, but using this product helps to increase tear production, and the side effects are very much what you get from oral varenicline for smoking cessation. Can cause a lot of nausea and headache, and then insomnia, cough, and throat irritation. Some of the serious side effects, which we're seeing in some of the post-marketing reports with plain varenicline for smoking cessation, include suicidal behavior, and it used to be a black box warning, but they've taken it off because they really couldn't prove that causality. But I would still caution the patient, if you do prescribe this medication, monitor their moodiness, if they start to feel depressed or they have suicidal ideation, we need to intervene. So still a possibility. All right. I think this is no, two more agents. This one is interesting. Perfluorohexyloctane. I don't even know how to pronounce that. But Meebo, this one is generally it's actually all chemical based. There's actually no drug related action going on here. All it does is it rapidly spreads across the ocular surface because it has a really low surface tension, and it has empaphilic properties, and it forms this very stable tear film layer on your eyes. Um, so that's all it does. It's purely physical. There's no pharmacologic activity happening. So if anyone has like side effects because of drugs, this one's probably their best bet. And then lastly is this thing called topical tamarind seed polysaccharide. It is effective for short-term symptoms. It's very similar to the Meebo here. It forms a stable layer on the surface of the eye, which then helps promote lubrication. All right, so stepwise approach to dry eyes. Step one, see if you can use OTC stuff. Step two, um, find this is more. So step two is more secondary causes of dry eye. I don't know if you guys have heard of the Demodex. It's a like parasite that causes dry eyes. It can cause like blepharitis. So if you identify that, you're gonna have to kill them. So you can use ivermectin cream to kill the little parasite, or this XDEM V drop. Um, and then after that, if you've identified Demodex, kill it. If there is no Demodex, then you can use any of these pharmacotherapeutic options I've just listed. Step three is more like resistance. If it's still the patient's still having dry eyes, there's something called like platelet-rich plasma eye drops that they can use, or therapeutic contact lenses. And then step four, topical corticosteroid. We can use that for a little bit longer duration, and then after that, it's going to be kind of more surgical approaches. So in summary, insufficient tear production, excessive evaporation of the tears, which is more common. A lot of interventions that we can apply, and then varenicline nasal spray is the newest agent going through that trigeminal pathway. All right, questions? Do you guys need a break, Sunita? Everyone's good. Okie dokie.
So if someone has like trigeminal neuralgia, would we not use the trigeminal pathway nasal spray?
I don't know, Mandra, but that's a great question. I would assume we would not.
Thank you.
I think I'll look that up too. Um, if I remember correctly, if you have trigeminal neuralgia, crying is kind of the one of the symptoms. So yeah. Oh, don't worry, Tin. I'll see you after class. We'll give you a list. Varenicline, nasal. Great question though. Okay, drugs for the skin. What's that? More chatty stuff. All right. Um, Various formulations, right? I'll just kind of give you some of the highlights here. Ointments, we all know, are kind of oily. When you compare that like gram per gram versus a cream, you generally get more drug out of an ointment because of its lipophilicity. Drawbacks, it's oily. People may not like the ointment of it, you know. It's greasy, right? So that's some of the drawbacks. Creams, generally better, well tolerated. Lotions, basically same as creams, but usually scented. Gels are they're kind of like the alcohol component to it that causes that gelish form. So it's usually gels have a cooling effect, but can irritate the skin, especially if they are sensitive to like the alcoholic formulation. Foams are nice. A lot of the, or some of the testosterone type formulations come in foam, so you could just kind of like, foam it and rub it in. So for ease of use and administration, it's nice that way. Everyone knows what a powder is, and I'm sure everyone knows what a paste is. All right, topical glucocorticoids. We use them for all kinds of things, right? So inflammation, itching, all that good stuff. Local reactions, thinning of the skin, which is common, stretch marks. This picture here that we're looking at, I don't know if anyone knows what this is, but this is a telangiectasia. So it looks like a spider web-ish of vessels. Hypertrichosis or growth of hair growth, are all local type side effects. Systemic toxicity, yeah, pretty hard, I think, to achieve that if you're just doing topicals. But again, it depends on the potency of the steroid, where you apply it to. Have you guys heard of the term intertriginous areas? So your intertriginous areas are just kind of areas of your body where like your skin kind of rubs against each other, which then introduces a lot of moisture. So think about like underneath the breasts, your armpits, the inner part of your thighs, like things were just kind of naturally just kind of rubbing up on each other. If you apply medications to those areas because of the rubbing, generally there's higher blood flow, and so there's going to be a bit more absorption of medication in those areas. So really, with like glucocorticoids, especially the higher potency ones, you want to tell the patient like, don't rub it in those intertriginous areas because you might get more systemic absorption. Don't use occlusive bandages. So sometimes you can use these for therapeutic purposes, especially if you like dry skin. You can use like Lachydrin or some of these moisturizing creams. And if you wrap it, sometimes people use like saran wrap. You can actually wrap that area, and it actually kind of helps to maintain the moisture or increase absorption. Obviously, if it's like a steroid, we don't want to increase absorption, so you gotta tell people don't wrap that area. All right, this is kind of a super easy chart, but it's probably good to know the potency of these things. I'm pretty sure they'll ask you on your boards. You can see that the highest super duper increased potency one is clobetasol, then followed by like fluoxetinide, betamethasone, triamcinolone is kind of like in your middle, and triamcinolone comes in various strengths. And you can see here, right? So triamcinolone 0.1% ointment is going to be more potent than triamcinolone 0.1% cream, which makes sense. We just talked about that. Hydrocortisone sucks, it's weak. And then this is your over-the-counter type hydrocortisone, right? Comes half and 1%. All right, I'll pause there. Any questions so far? Steroids, good. Okay. Chronolytic agents, this are help promote shedding of the stratum corneum, basically for dandruff or seborrheic dermatitis. But we use two agents, salicylic acid or sulfur. If you've heard of these, like salicylic acid, Selsun Blue is kind of a common over-the-counter formulation for this, but it helps with kind of that dry scalp and the flakiness of dandruff. Acne. Here are your guidelines if you want to take a look. Everyone knows what acne is, so I'm not really going to go over all that. I would look at, I don't know if I talked about it. Yeah, maybe not. Just to look for any like medication causes. But anyway, so additional testing here, non-pharmacologic interventions, really not too many are helpful. So a lot of these folks will go into straight pharmacotherapy. Um, you can classify the acne severity, and this is kind of the classification here. So treatment, drug therapy, everyone's seen benzoyl peroxide. I'm sure many of us have used it when we were in our teens. So that's over the counter, many formulations. Just remember, benzoyl peroxide tends to be a bleaching agent. So if you consult your patient, tell them, don't rub your face on that favorite colored sweater you have. Otherwise, it's going to bleach it. We do also use antibiotics. Generally, it's clindamycin or erythromycin. And then these are the topical retinoids, so tretinoin or Retin-A, adapalene or tazotierine. These also help with acne. You can also use keratolytic agents. Salicylic acid is also available over the counter for acne. Isotretinoin is usually the Cadillac of acne treatments. It's kind of like what you go to if you've tried out all the over-the-counter products and they still suffer from acne, or they have such severe acne that's causing scarring. Then isotretinoin is kind of your go-to medication. I've had friends use isotretinoin. It's pretty great medication in helping with acne. Um, just remember, it goes through the REMS program, which is what they call iPledge, specifically for isotretinoin because it can cause birth defects. And so you got to make sure that you've done pregnancy tests for both males and females. For hormonal agents, the ones that are useful for acne, oral contraceptives, but specifically spironolactone and drospirenone uh, have been have been shown useful for treating acne. Any questions on acne? Okie doke. What about psoriasis? I won't go into a super detailed review of psoriasis, but steroids can be used. We all know what the side effects of steroids are, so generally we don't want to use it for too long. They do have vitamin D analogs. I can't remember the name, but also tazotierine, uh, Tazorac, Anthralin, coal tar. Coal tar is you can get this over the counter. It's just stinky. I don't know if anyone's ever actually dealt with coal tar. It's like sludgy and stinky. It is work. It does work. But this is just kind of some of the drawbacks. And then some of the newer agents are roflumilast, which orally is used for COPD, and this other agent, tapinarof, and calcineurin inhibitors such as tacrolimus or cyclosporine can also be used. These are the professional guidelines for treating psoriasis and some more. And the most common one's plaque psoriasis. That's kind of the type of psoriasis you think of when you think about psoriasis. There's also pustular psoriasis, which looks kind of nasty. This one, guttate psoriasis, I think I'm pronouncing that right. It looks like droplets. So if you just want to Google that. And then these other types of psoriasis. Various genetic factors generally cause psoriasis. Can also be caused by skin trauma, and then also smoking as a predisposing factor. Medication-induced psoriasis. Here's the mnemonic is nails. So NSAIDs can do it, anti-malarials or ACE inhibitors. Inderal, which is the brand name for propranolol, but basically beta blockers. Lithium can do it, and then if you do steroid withdrawal. Some medical comorbidities are commonly seen with psoriasis, including autoimmune diseases, so think like lupus or rheumatoid arthritis. Some cardiovascular diseases, metabolic syndrome, lymphoma, melanoma, and depression, suicide. All right, I'm sure you've seen psoriasis, red, raised, scaly patches. Lesions can occur. About 50% of patients will have evidence of fingernail involvement because they'll just start to like scratch at it. And then there's estimates of psoriatic arthritis in patients with skin psoriasis that vary anywhere from 6 to 42%. And unfortunately, psoriasis can occur anywhere, arms, legs, buttocks, genitals, so on and so forth. Diagnosis is usually made by visualizing the lesions, and then testing is rarely ever indicated, but can be used if need be. All right, so usually we'll just look at how much of the percentage of body involvement is involved. So if it's mild, it's going to be less than 3% of body, moderate 3 to 10, and then severe is going to be greater than 10%. Here is the flowchart for kind of psoriasis. You can see you start off the top, diagnosis, and then you kind of go down the line here. If the scalp is involved, we can use any of the anti-dandruff type of keratolytics, like salicylic acid. And then, if it's not, then you're going to go with like steroids or a vitamin D analog. And then if it's really, really severe, you're going to go with kind of more higher potency type stuff, like retinoids. If you have to go through systemic therapies, we have methotrexate, which we've kind of covered with rheumatoid arthritis. There's one called Soriatane or acitretin. This one's a more newer one, came out like in the last 10 years, Apremilast or Otezla. And then cyclosporine, which is a calcineurin inhibitor. Generally, we don't want to use cyclosporine systemically because of potent side effects, namely hypertension. We do have a lot of biologic agents, so just kind of remember all the things that go along with biologic agents. Usually all injectable. They can cause injection site reactions. Because they're immunosuppressants, right? You do need to make sure that they're tuberculosis free, and that they had a Hep panel done. But otherwise, you can see that adalimumab or Humira can be used, certolizumab or Cimzia, infliximab or Remicade. All of these agents can be used. Corticosteroids still remain kind of a cornerstone. We kind of talked about that. So in summary, severity is defined by how much of the body surface area is being affected. Topical medications are generally first line. If it's more severe, then we'll have to start using more of the oral agents or maybe some of the injectables. Your tumor necrosis factor alpha inhibitors, interleukin blockers, or monoclonal antibodies are usually reserved for moderate to severe psoriasis, or if it's very debilitating to the patient. All right, questions on psoriasis or anything else that I've covered? Nope. Okie doke. Next is eczema. It's also known as atopic dermatitis. Here's where we're going to use, again, glucocorticoids, but moisturizers. These other ones like tacrolimus or pimecrolimus are your non-glucocorticoid topical immunosuppressants. So these are kind of nice because they are devoid of all the steroid side effects. Elidel is actually pretty common in children, so it can be used for that purpose. And then this one's a PDE4 inhibitor called crisaborole or Eucrisa. For wart removal, if you've seen venereal warts, it's also known as Condyloma acuminata. You can use podophyllin. There's a topical agent called imiquimod or Aldara. Also Podophyllix or Condylox. And then there's this other one called Veragen ointment, which is a botanical ointment, and it's derived from green tea leaves. That could be used for that. For common warts, you do cryotherapy, curettage, laser therapy, and then a lot of this is also available over the counter, right? So salicylic acid can be used to kind of like burn off the common wart, but you can also use imiquimod or Podophyllix, which are used for venereal warts. Drugs for ectoparasites. Ectoparasites are just parasites that kind of live off the exterior of a host, feeding off of that, right? So pediculosis is kind of your common ectoparasite, and we use permethrin, which is Nix. It's available over the counter. It's 1%. These lead to they're neurotoxins to the parasites, so they cause paralysis, and then the parasite dies. You can also use perithrins, which is red. There's been more resistance to this type of agent over the past couple of decades, so we usually don't rely on red too much. Other agents include malathion or spinosad, and then something called lindane. Lindane's a little weird. It can cause seizures, and so generally we try to avoid that. And if I remember correctly, especially if you shower, I think the water or some the heat can increase the amount of lindane you get, and that can cause or predispose you more to seizures. But I gotta look that up first. But in any case, lindane out of all these agents can increase your risk for seizures, so we try to avoid that. Seizures. And then ivermectin, which everyone knows what that is. Okay, other ectoparasites are scabies. Who here has dealt with scabies? Always fun time at the hospital when scabies is called. Permethrin is the go-to. You apply this basically head to toe. You give it a week or two, and then you apply it again. And then you just kind of get out of the way. If the agent doesn't work, you can start to use the other agents like ivermectin or lindane. Okay, other skin conditions, impetigo, an infection, usually from staph. You're going to use antibiotics. Causes a lot of like this golden redness crust, usually in like kids. Skin cancer, just make sure to recommend sunscreen. So check the SPF, make sure it's a high SPF. If you suffer from wrinkles, Botox is kind of your thing. And then if you have seborrheic dermatitis or dandruff, which we've already covered, but ketoconazole is also an agent that can be used, usually as a ketoconazole shampoo. That can also be used for treating dermatitis or dandruff. What if you have hair loss? If you have hair loss, you can use minoxidil, which over the counter is also called Rogaine. Does anyone know what we use minoxidil for other than hair loss? Does anyone remember? Oh, someone's on the chat. Hey, blood pressure. Well done. So, minoxidil can be used, safe in pregnancy, so it's a direct vasodilator, can be used for blood pressure, but it makes people hairy. Unwanted hair, what if you're too hairy? Well, there's an agent called Vanica or eflornithine that helps to kind of reduce cell division and the hair follicles. All right, topical stuff. Not too bad. Any questions? Everyone good? Okay. Drugs for the ear. Acute otitis media. I know we've covered this before, but just as a reminder, because it's probably going to be the more common pediatric situation you run into. Treatment is high dose amoxicillin, which is 90 mgs per kilo per day. So just make sure you remember it's per day. Generally, it's divided to 2 to 3 times a day. If you have antibiotic resistant otitis media, then Augmentin, which is amoxicillin clavulanate, which is recommended. You're still going to aim for that AMOX component to be 90 mg per kilo per day, and you're still going to divide it. But the clavulanic acid part of Augmentin should help to keep amoxicillin alive against more resistant pathogens. Especially first line if you have a higher likelihood of H. influenza. And just remember, if you're in kind of smoker territory or secondhand smoke, those folks tend to have more H. influenza than the general population. Antibiotic therapy should be done for 10 days. This is one where, like, if you do it less than 10 days or a lesser amount, it tends to cause more treatment failures. So for once, we're going to treat for a little bit longer period, at least 10 days. If you have a penicillin allergy, it's not recommended to do cephalosporins because they don't really do a great job against your normal pathogens. If you have to, and really, if you have penicillin allergy, that's been all debunked now, right? You can kind of use cephalosporins. Most of the time, you're not going to have any issues. But if you do actually have, like, let's say a specific cephalosporin allergy, I'm sorry, if you really need to use an oral cephalosporin, then these are kind of your agents to use. Cefdinir, which is Omnicef, cefuroxime or cefpodoxime. If you have severe allergy, and let's say they have the actual cephalosporin allergy, then macrolides or clindamycin are your alternative agents. Prevention, here are the preventatives for avoiding acute otitis media, so I'll let you read through that. Recurrent otitis media, this is what happens if you have it 3 or more times within a 6 month period or 4 or more times within a year. Again, you can give them antibacterial therapy. Sometimes you can give prophylactics, but a lot of these folks will, a lot of these kids will start to have tympanostomy tubes. Kevlex, no, I've never. Kevlex doesn't cover usually your typical pathogens very well. As a first gen cephalosporin, um, it's like okay against streptococcus. Definitely doesn't cover staph. And I think I wrote it there. Yeah. For a skin infection, Keflex can be used to cover strep, and then you usually combo that with Bactrim to cover staph, but it's usually not super strong. Um, so we generally don't do that. Okay. If you have otitis media with effusion, this is generally a watchful waiting situation. So that's that. Otitis externa, or commonly known as swimmer's ear, your general pathogen for this is going to be Pseudomonas. That has about 20 to 60% prevalence, or Staph aureus, which is anywhere from 10 to 70%. Um, and you can use topical treatment. Usually it's acetic acid plus alcohol. The alcohol is there to kind of help dry up any water. The acetic acid can be kind of an antibiotic. Um, you can also use the fluoroquinolones, and so because there's really no absorption through the Oda canal, fluoroquinolones are going to be safe even in kids. You don't need to worry about that tendon rupture stuff. So just kind of remember that. And also, all the fluoroquinolones should kill Pseudomonas, and so it's a great agent to use if you suspect Pseudomonas as your causative pathogen. If you have to resort to oral treatment, usually you don't need to, but if you have to, then again, do fluoroquinolones for the adults because of the ability to kill Pseudomonas. If it's children, again, don't do it because of the tendon rupture thing. And preventatives, these are the folks that swim a lot, so maybe they need to invest in some earplugs. Or if you like to use Q-tips, that's kind of problematic, right? Because either they remove the earwax, which is going to be a defensive mechanism, or they start to have cerumen impaction where they're just jamming all their earwax into them and then they have a hard time hearing. Necrotizing otitis externa is your otitis externa that's kind of looks like really crusty and nasty on the outside. Again, you're going to use Cipro because more likely than not, yeah, you're dealing with Pseudomonas here. You can have fungal otitis externa or otomycosis. Use the acidifying eardrops, like the acetic acid I was talking about, or you can use antifungal eardrops as well. Oh, I'm done? Oh, that was short. Yay! An hour. Nice. Alrighty. Well, good luck on quiz 6. I'll start working on the final exam and come up with a study guide. But otherwise, it's been fun. You guys all have my number and email. Feel free to message me. But otherwise, if I don't see you, I'll see you in the spring. Is that the next class? Where we talk about herbals. We're just going to talk about marijuana. Just going to talk about weed. All the good things weed can do for you. Cool. Oh, chat. Oh, thank you, man. John, you're too kind. All right. Otherwise, if you can make it, I will see you then on November 30th. Bye, guys. Have a good night.
Thank you.
No problem. Adios.
Thank you, Doc.
We'll see you at the next CNT meeting.
Oh, sounds good.
Bye.
Bye.
Bye. Thank you, Doctor.
Bye, Avninder.
Bye. Thank you, Doc.